Okay, I thank Dr. Santosh and the organizing team of Coffee with CFS for this opportunity to present my work. So I'll be presenting a short case series on Rickettsial retinitis. My first case is a 28-year-old female from Mehboob who came with right eye decreased vision for 1 week. She gave history of fever, headache, and skin rash 3 weeks back. This is a picture of the healing rash. Her best corrected was 618 in her right eye. This is the fundus picture. You see areas of multifocal retinitis with occlusive vasculitis. And this is the left eye, which is normal. The OCT B scan shows vitritis and inner retinal hyperreflectivity with shadowing. Her wheel Felix test came out to be positive, and I treated her with oral doxycycline followed by oral steroids. After a month, her retinitis lesions had resolved, but we see a largely ischemic retina here, and the OCT shows inner retinal atrophy with loss of outer retinal layers. However, her vision had improved to 6 parts. This is the OCT angiography picture. The superficial and deep plexus show areas of capillary non-perfusion. We'll discuss about this later. Coming to my second case is a 70-year-old male from Bidar, Karnataka with decreased vision in right eye for a week. He again gave history of fever, headache, skin rash 2 months back. He's been a diabetic for 20 years and his best corrected was hand movements in his right eye. So this is the fundus picture of the right eye with multifocal retinitis patches and occlusive vasculitis. Again, the OCT picture shows inner retinal hyperreflectivity with subretinal fluid. The OCT angiography shows capillary non-perfusion in superficial and deep layers. The outer retina and the choriocapillary slab show apparent flow void, which is because of signal loss, and this is not true loss. The wheel Felix test was again positive in this patient, but because this patient was an uncontrolled diabetic, I decided not to give him oral steroids. So initially we treated him with oral doxycycline, which was followed by PST triamcinolone. So this was the improvement after about a month. His final visual acuity was 6 parts, though we see a lot of ischemia in the retina, but patient was happy with the vision. And here we see inner retinal atrophy with loss of outer retinal layers. This is the OCT angiography picture again. Here you see capillary non-perfusion again in the superficial and deep plexus. And this area that you're seeing is an apparent flow void because of signal loss in the outer layers. Coming to the third case. Third case is a 50-year-old male from Hyderabad. Again, history of fever, headache, skin rash. Best corrected was 612 in both the eyes. So this is the picture of the rash in the upper and lower limbs. The rash is still looks active. These were actually small pustules. This is the fundus picture showing multifocal retinitis in both the eyes. And this is the OCT picture showing inner retinal hyperreflectivity. There was not much of ischemia in the octa, but the outer retina and choriocapillary slab again show apparent flow void, which is because of signal loss from the retinitis patches. Wheel Felix test was positive. Now, since in this patient we see active systemic rickettsiosis with an active rash, I decided not to give him oral steroids. And this patient was treated with oral doxycycline, and about after 4 or 5 days, I gave posterior subtenon triamcinolone in both the eyes. And this is the resolution of the rash, and the retinitis patches have disappeared and vision has improved to 6/6. And in this patient, because he presented early, the retinal morphology is maintained. There's not much of ischemia except for a small non-capillary perfusion in the left eye, in the superficial and deep capillary plexus layers. Coming to the fourth case, this is a 35-year-old male from Gulbarga, Karnataka. He came with decreased vision for 2 weeks. and his best corrected was 624 parts in the right eye. Now, this patient was being treated as a toxoplasma retinochoroiditis because of the pigmented scar that he had. But if you see the OCT, this is actually a retinochoroidal coloboma, and the retinitis patch here is a separate lesion there. So this patient also had a subretinal fluid, which was causing the decreased vision. Not much of ischemia, only signal loss that we see in Octa. Wheel-Felix test was positive. Again, because of the previous experience, I thought just for one eye involvement, I don't want to give oral steroids. And again, PST triamcinolone was given after oral doxycycline. And this was the response to treatment after about a month. Octa did not show much ischemia in this case. He responded very well. Now, case 5, this is the last case, is a 42-year-old female from Hyderabad. She, again, with the right eye, decreased vision for the past 10 days. She was already on high-dose oral steroids, started elsewhere. And after steroid treatment, her vision had actually worsened. This we rarely see in uveitis. Her vision had worsened to 6/120 in the right eye and 660 in the left eye. So she came for a second opinion. Now here you see the retina looks very dry, ischemic, and the optic nerves look pale. There is a little retinal thinning also that you can see, although there is inner retinal hyperreflectivity. I wanted to rule out collagen vascular diseases like SLE. We checked her BP, her ANA profile was normal, homocysteine was normal, MRI brain was normal, and Wheel-Felix was again positive. So this patient, we just added doxycycline, and she responded well to treatment, but there was significant pallor of the optic disc, and there was retinal thinning. Though her vision had improved to 6/669, but she had significant visual loss. So now coming to a little background about the disease. So Rickettsial are intracellular parasites. They are gram-negative pleomorphic rods, and they cause spotted fever, typhus, and scrub typhus. They infect arthropods and reside in their alimentary canal. When these ticks and mites bite humans, they have this flea feeding reflex where while they are feeding on the human, they defecate. And that's how humans get infected. And they invade the vascular endothelium and reticular endothelial cells. Now, humans are the dead end of transmission, and there is no human-to-human transmission in Rickettsial. So this is about this table just shows the diseases that rickettsial organisms can cause. So systemic rickettsiosis has been reported from all over the world. In India, it has been reported from these states, but there's been no report from AP and Telangana yet. It causes 30 to 35% mortality. The basic pathology is vasculitis, which leads to skin rash, inflammation, and end organ ischemic injury. Patient presents with high-grade fever, headache, rash, and history of exposure to tick bite or dogs. Coming to the diagnosis, now IgM antibodies by IFA is the gold standard, but this test is very expensive and it's not routinely available in our country. So we have to rely on a heterophile antigenic test, which is the Wheel-Felix test. Now this test is based on the cross-reactivity of rickettsial antigen with Proteus. So the sensitivity is low, but the specificity and accuracy is fairly reliable. Coming to ocular imaging, Octa has been found to be better than fluorescein angiography in detecting and characterizing areas of capillary non-perfusion that we have seen in our cases. And it's an important tool to study the occlusive complications in this disease. Treatment with only steroids may cause worsening, like we have seen in our last case, and antibiotics with or without steroids lead to resolution of the lesions. Coming to the differential diagnosis of multifocal retinitis. So West Nile virus is known to cause infiltrates along the nerve fiber layer. Lyme neuroretinitis causes a neuroretinitis and affects the optic nerve more commonly. Dengue retinitis causes fovealitis. And again, we can also rely on the IgM antibodies and NS1 antigen to diagnose this. coming to Chikungunya retinitis, this is another cause of multifocal retinitis, but it can be differentiated from rickettsial retinitis by the significant history of joint pains and, of course, the IgM antibodies. A retrospective study on acute multifocal retinitis found that rickettsial retinitis is the most common cause of multifocal retinitis. So a few take-home points. History and systemic examination give important clues for diagnosis. Weil-Felix test is specific when positive. Early treatment with doxycycline improves prognosis, and Octa shows capillary non-perfusion in superficial and deep capillary plexus, and it's useful to study occlusive complications. Thank you.
Thank you so much, ma'am. Those were a series of very interesting cases. I'm sure none of us, the residents or the fellows, would have seen so many cases of rickettsial retinitis as such. Dr. Vanita?
Abhilasha?
Yes, sir. Yes, sir.
Can we ask, Mritika, can we ask some questions here?
Yes, sir. I'll be happy to answer.
Or unless somebody is discussing this case, maybe later on.
No,
The issue was that somehow in Delhi, at least I haven't diagnosed. I'll ask my friends also. So, is there any regional prevalence? One question is that. Second is, can you suspect without, because all your 5 patients had rash. So, can you suspect this without rash? And third was the dependency on this Weil-Felix test.
Thank you, sir, for the questions. So the first one that you had asked about the regional propensity for this disease. So this disease is most commonly seen in Karnataka. It is most commonly seen in South Indian states, and Sri Lanka has also reported a lot of rickettsial cases, and including rickettsial retinitis. And these diseases are generally seen 2 to 3 months after winter. So there's a study by the Sri Lankan group where they have shown that after most of their cases come after December, January. So they present in February, March. The second question, that reliability on rash. So a rash is a very important clue in this disease, because if you see the other diseases like chikungunya and dengue, so the rash gives is an important clue to the diagnosis. Suppose the patient comes without the rash, then probably we'll have to do the other IgM antibodies also, like chikungunya IgM antibodies or dengue antibodies, to make a specific diagnosis of this condition. And about that Weil-Felix test, the sensitivity is low, but the specificity is very high. So there are no false negatives. The positive predictive value is close to 100%. So when the test is positive, the patient is more likely to have.
I know, because from RP Center, I think I had spoken once to Dr. Rohan. He had shown one case in, I think, DOS conference, where I think because of the Weil-Felix test only, they had done IgM, and that clinched the diagnosis.
So IgM is there in CMC Vellore. They are doing IgM antibodies for rickettsia, but as in Karnataka also, I was earlier in Bangalore. I did not find any lab that was doing IgM antibodies for rickettsia.
But must compliment you for all your 5 cases, very well documented, and excellent photographs you have shown. Very nice.
Thank you, sir.
Sir, any clinching point in diagnosis of rickettsial retinitis, how we distinguish from other retinitis?
Abhilasha?
Yes, sir, thank you for the question. Sir, if you, like how I said, it is difficult to differentiate chikungunya from rickettsia, because both will cause multifocal retinitis with vasculitis. But in chikungunya, the anterior segment inflammation is more common than what you see in rickettsia. That is one point. And IgM antibodies in chikungunya have a better sensitivity than wheel Felix test. So that is a differentiating point. Other than that, the presentation of Lyme disease is, again, it involves the optic nerve most commonly. And in those cases also, we can do IgM antibodies. West Nile virus will be along the nerve fiber, along the nerve fibers. It will be linear, and Rickettsial is along blood vessels.
Basically, you will have to make a diagnosis on wheel Felix test. You cannot make a clinical diagnosis. You come to a diagnosis of retinitis, and then you point out 3 to 4 differential diagnosis,
Yes,
and
sir.
you order the investigation accordingly. That's
Yes,
how
sir.
I'll approach to this case.
Yes, sir. Yes, sir.
The biggest learning has been that any patient who has multifocal retinitis with the component of vasculitis,
Mhm.
we should ask history of skin rash or fever preceding that, and then order for wheel Felix. That's because all her 5 cases had history of fever and rash, and all of them had focal retinitis, multifocal or unifocal, and all of them had characteristic OCT picture with inner retina involvement. That is retinitis basically.